I hope everyone feels relaxed and rejuvenated after that meditation session. I know I do. Thank you, Dr. Bahadirani, for leading us to meditation during the break. We have made it to breakout session number 2, and we have a treat for you all. Reminder, please use one admin question to ask questions throughout the session. The next presentation will be an intimate conversation with patient advocate Kommah, Koko McDowell, and physician scientist Dr. Veronica Jones on the importance of shared decision-making in breast cancer treatment and engagement of community stakeholders and research. Dr. Veronica Jones specializes in breast cancer surgery at City of Hope after serving as an assistant professor of surgery at Emory University School of Medicine in Atlanta. Her research is focused on health disparities in underserved populations, as well as new technologies in breast cancer care. Koko is an inspiring and proven leader who currently serves as a national patient speaker for City of Hope. She's a triple-negative inflammatory breast cancer survivor, wife, and mother, despite the statistics. She has over 20 years of being a dynamic public speaker with a mission to make a difference for those fighting for their lives. Koko will work alongside those in the trenches and help make what seems impossible possible. Today we will listen in on an ideal patient-doctor and patient-researcher relationships conversation. Dr. Jones and Kommah McDowell, welcome to the stage.
Thank you. Thank you very much. It's an honor to be here with you all. I'm excited to share with Ms. McDowell what an ideal patient-doctor relationship looks like. Can you all hear me okay?
Yes, we can.
Okay.
Dr. Jones.
Okay, great. So as Jillian said, I am a breast surgeon and researcher at City of Hope. I spend about half of my time doing surgery, and then the other half of the time doing research on a particular type of breast cancer that affects African American women. And that research is done in a lab and also with patients. And I'm so excited to talk to my friend, Ms. McDowell, about her experience and how we can make the patient-doctor relationship better moving forward. So thank you, Ms. McDowell, for being here.
I'm excited. This is a great opportunity.
Great. We were going to start off with just a little bit about Ms. McDowell. And she has a very interesting story that really typifies kind of what we should learn about from a patient-doctor relationship and also from a patient-researcher relationship. So I just thought we'd start with hearing more of her story.
Awesome. So to give a little background, I am a 15-year triple-negative inflammatory breast cancer survivor. I was diagnosed at the age of 29, and my diagnosis, the process to get diagnosed was very sad yet familiar for young survivors or young women diagnosed. I was told that I was too young to have cancer, and especially breast cancer, because I was only 29 years old. I had actually gone back and forth to my doctors every 2 weeks complaining of different symptoms and pains. But because she wasn't familiar with them, she just considered it as a hormone thing because I was young and my hormones were just changing, and to give it time, it'll all go away. And so through the course of 7 months, something new would appear and I would find myself back in her office. I had inflammatory breast cancer, and especially in 2005, that was not a common cancer. So most doctors at that time were not familiar with the symptoms, how it presented, and my doctor wasn't. And not only was she not aware of it, but the surgeon she sent me to a breast surgeon, he wasn't familiar with it either. And both of them told me that despite all my symptoms, which included my right breast growing to be double the size of my left, the skin texture changed to look like an orange peel. The nipple would invert. It was excruciating pain. I had a lump under my right arm the size of a golf ball. So despite all of these symptoms, I was still told that it's not cancer because you're too young to have cancer, and breast cancer doesn't hurt. And that was what they were willing to just stand on. And thankfully, that wasn't enough for me. And I insisted on them taking out of me whatever was not wrong, because obviously there was something growing inside. And so when they opened me up, it was at that point, which was in July of 2005, that they found cancer. And fortunately, I was familiar with City of Hope. And so I made my way to City of Hope for a second opinion. And it was there that I learned that I not only had breast cancer, but it was triple negative inflammatory breast cancer. And once that diagnosis was given, then I underwent chemotherapy through City of Hope. I had chemotherapy, a radical right mastectomy, and then I had radiation therapy. And then July of the following year, 3 more lumps appeared on my left. And we watched it for about 6 months and I couldn't take it anymore. So then I ended up having, a year later, I ended up having a mastectomy on my left. And so I ended up with reconstruction once they did the prophylactic mastectomy. So my journey is pretty extensive. I've had honestly over 10 surgeries, and it was really the fight of my life to get to a point where they would listen to me. My doctors would listen to me. And so now as a patient advocate, 15 years later, let me back up real quick. I was told when I was diagnosed that I had a 5% chance of surviving 2 years. And so I'm here 15 years later, and that says a lot. I was also told that I wouldn't have any children. And I have a son who is 11 years old, and he's healthy and strong. And so despite the statistics and honestly what was happening, the trend, it was a 95% mortality rate, I'm still here. And being here now says to me that I have a role to play. I have an obligation to be a voice for those who are not here to have a voice in this fight against cancer. So does that give you the backstory, Dr. Jones?
That is awesome. That says a lot. And yeah, I saw in the chat, praise God. Yes, praise God that right. You are here and with us, and just an amazing story. So I wanted to share with everyone a little bit about why we're even having this conversation. There has not been many ideal patient-doctor relationship stories, and there's a reason for that. And so I'm just going to go through a little bit about some of the statistics, a little bit about the history, and then we're going to get right back to Mrs. McDowell and talk about her perception of what makes an ideal patient-doctor relationship and how we can do that as a community. I was going to just let everybody know about kind of the history of what has defined patient-doctor relationships, especially among minority communities. And, there's a lot of mistrust, honestly, in many communities of color with the healthcare system. And there's a lot of reasons for that. I think the best summary that I found was by Reverend Baker, who gave a presentation one time that said that there are reasons for mistrust, including historical betrayals of trust. And of course, that includes Tuskegee experiment, which many of us know about, as well as HeLa cells, which again, many of us know about. But there have been these historical moments in time where the healthcare system has publicly enraged minority communities by taking advantage of them. And there are many feelings of that still that persist in multiple minority communities, not just African American. On top of that, there's current difficulty in accessing and understanding healthcare. Many communities either speak another language than the healthcare professional that they see for their care, or they don't have the access that they perceive and realistically don't have that same access as other communities. And that also puts in a layer of mistrust which puts up a barrier between a certain patient and the doctor or the researcher who's taking care of them. Okay, thank you. The last reason kind of that Reverend Baker went over in this discussion on what causes mistrust in minority communities is inherent bias that is expressed by the physician that is taking care of the patient or the researcher that's talking to the patient. There's bias, there's discrimination, there's very clear disparities in healthcare, and everyone sees them, right? And so this also puts up an additional barrier. So we have the historical barriers put in by series of just enraging acts by the healthcare system on minority communities. And then feeding into that, we have current difficulty accessing and navigating care, current bias and discrimination, which compounds just the feelings of mistrust that many patients have for doctors and researchers. And as you can see on the screen, the percentage of Americans who report confidence in the medical profession is decreasing, right? It was at 75% in 1966 and it's gone down to 38% last recorded in 2019. I know with the current political climate, with the current racial climate, I don't know what the percentage would be this year or what it will be next year. But the fact of the matter is we're getting worse, not better. And we need to change that. Can you go to the next slide, please? So why is this important? Why do we even care if patients have a mistrust of either the doctor or the researcher? It impacts multiple levels of care. And I have in here that first it affects treatment, right? If you don't trust the person who is telling you, oh, you should take this medicine, you should do this regimen, or you should participate in this trial, you're not likely going to receive the information that they're giving you and may not even do it. And so I found multiple studies that will prove this, and I put up some statistics here, such as patients with the highest level of distrust have a 22% less likelihood of receiving a recommended treatment. And that may be a treatment that saves their life. The relationship affects outcomes, right? So lack of receipt of that treatment is actually associated with, we're talking about breast cancer here today, a 40% increased risk of breast cancer recurrence, meaning your chance of the breast cancer coming back is 40% higher based on whether or not you receive the treatment that the physician or the researcher, or not researcher, but the physician is recommending to you. Relationship affects discovery, right? If you don't trust the researcher in front of you to participate in that research, then you're less likely to participate in that trial. And those trials are how drug discovery is made. And so we know that over 80% of clinical trial participants are white Americans. And these are drugs that are being developed for all people. The question comes into play, how do we know that these drugs are working in other populations? We don't, because the lack of representation in clinical trials is there. In fact, we're discovering now that chemotherapy drugs that were developed primarily for and by white Americans causes cardiovascular disease in African American women. And so we're finding out those things on the back end. But that's part of just not having adequate representation in clinical trials. And the relationship affects everyone, right? I've been saying multiple minority communities. There was a study done looking at distrust across many ethnic minorities, and it was found that distrust was present in every single one. And so this is a topic that affects all of us, and one that we need to grow from. And I know Ms. McDowell will give us great insights on how we can grow from this. Can you go to the next slide, please? After this talk, if you want to just do some more research on your own about how we got here and maybe how we can grow from here, I included some books that if you want some light reading, it's not light at all. This is very heavy books, but it's essential, right, to moving forward. There's medical apartheid, the health gap, and then, of course, by our own Miss McDowell. Silver lining, I thought that would be a great insight into the patient-doctor relationship and how it affects just the patient in general, their overall experience, and how they rise from it. So with that, I think we're going to turn our attention to just an interview dialogue with myself and Ms. McDowell about patient-doctor relationships. And if anybody has any questions about those, we can discuss them at the end during the Q&A portion. So, Ms. McDowell.
Yes.
We would love to hear more about your experiences. And so I was hoping that you could start off with just telling us moments in your care where you felt heard and when you felt respected, right? Let's start on a positive note. When did you feel like your physician or your researcher heard you and saw what you were going through?
I have to say, for my care, I actually felt heard or seen. So first I was seen at my first appointment at City of Hope. We were so just lost. We didn't know, I was young and I had just gotten engaged, and we're looking at, my fiance and I were looking at, this life together. Now we're facing this. And Kathy Cole was my nurse practitioner, and she actually embraced me, and she kind of pulled me back and was like, I see you. And that was mind blowing for me, because I felt she saw me. She was there and paying attention to me. And then I thought, well, wow, that was a really nice nurse. And then I met Dr. Jeannie Shin, and she came in and she was so in tune and aware. They had my file because I was there for a second opinion, and she was on it. And I was like, wow, you actually, look into and you're not walking in the door just trying to skim the file as you come in, but right. She knew what she was coming in for. And so that meant a lot to me. And then for her to suggest an opportunity to meet an oncologist that is just so happens to be a specialist with inflammatory breast cancer, just so happened to be flying in that day to City of Hope to see about his other patients, would I want to take the time and wait to see him? And I thought, I had just been misdiagnosed for 7 months. I had a doctor that was at a point of telling me not to come back to her office. When she saw me, she was like, you again. That was the treatment I was receiving. I had a surgeon who I thought would at least consider some information, tell me it's against his better judgment to even move forward with any procedure because he completely agreed with the doctor. So to have a nurse acknowledge me the way she did, then have one doctor actually read up and know what they're looking for from me, and then to be recommended to another doctor who was willing to squeeze me into the schedule. From the gate, they saw me and They heard me. And that was beautiful. And then when talking to Dr. Somlo, I was set to be married in 3 months from the time I was diagnosed. And we told him that. And that was important to us. And we weren't canceling the date. And he said, okay. And we worked around it. We were a part of the team. They didn't just dictate care to us. We were asked our thoughts, our opinions, what do we think? They wanted to make sure we were okay and understood. So I have to say, from the gate, my care was amazing.
I love that. I love that you were a part of the team. That's so critical, and something that unfortunately is not present in a lot of interactions, but that's awesome. What about some things that maybe where you felt like the communication could have been better? My communication challenges all seem to stem from post-surgery. So it was not my care team and and my husband, we were on the same page. I have no complaints there. And I know that can be kind of unique, and some may think I'm trying to glorify it or all of that, but really our communication lines were very clear, and it may have a lot to do with the fact that my husband and I ask a lot of questions.
And so when we don't understand, we need to stop and make sure we understand before we move forward. So that helped with that. But my issue came in with post-surgery when I had to stay in the hospitals, and then dealing with the nursing staff at that point is when I actually had challenges, to the point where after I had my reconstructive surgery and mastectomy, we ended up leaving the hospital early because I was doing well. But when I got home, I realized we probably should not have gone so early. Although it looked clinically like I did well, I could have stayed another day or two, but I wanted to get out of there because I didn't like the way I was treated in that setting. So, which is, part of the journey.
Yeah, I think what's important in that is that it's all levels, right? That can affect your experience with the healthcare system. It's not just the doctor, it's not just the nurse, it's
Right.
everybody who has that touch point with you. And so this is an opportunity for improvement for everyone.
Yes.
Yeah.
Yes. And let me tell you, because my care was so great everywhere else, and it happened a couple of times during a couple of surgeries where I had this not so great experience, I actually wrote letters to the charge nurse detailing out what happened, how I felt about it, what I thought about it. I let, my oncologist know, I let my breast surgeon know. So it was known so that they could correct the care. Because I said, I know you provide better care than this as an organization. So this is a learning opportunity. And they thanked me for even doing that, because most people just kick, scream, have a fit, but they don't actually present it in a way to see that there's opportunity for change that needs to happen from this experience.
Right. That's so critical. And I'm sure you being a part of the team, feeling like you were a part of the team, maybe empowered you to take that next step, to give the feedback that's necessary for all of us to grow.
Exactly.
That is so key. Did you participate in research?
I did not. It's interesting, your stats before hit the nail on the head. And I was thinking about this. I was given the option to do a clinical trial for inflammatory breast cancer, because remember at the time, 95% mortality rate, African-American women were just not surviving this. I also had a triple negative cancer. The inflammatory breast cancer was triple negative. On top of that, just made things even more complicated. And so I remember Dr. Somlo, he was like, I'm going to throw everything I have at you. So, let's see, we're going to see what sticks. And so, okay, we made it through the first set of treatment. And by the time I was presented with a clinical trial option, I was done. I was presented towards the end of my treatment. And he was like, would you be willing to do a clinical trial for inflammatory breast cancer? And I couldn't do it. He was like, you'd have to go back through chemo again. And I couldn't do it. Had it been presented in the beginning and it would have been part of the process, I may have been able to do it. But coming at the end of the treatment and barely feeling like I survived that, I just couldn't do it.
Right. Yeah. It's so crucial. And I can say personally, as a researcher who does approach patients, I have learned to be very sensitive to the timing of when to present that research to the patient, because the research is not, it's important, but it is not the main objective, right? The main objective is healing. And so you have to understand where the role of research fits in that particular patient's experience. It needs to benefit them in addition to, medicine at large. I know we only have a few minutes left, so I wanted to open it up to questions from the audience, either for Ms. McDowell or myself, about building ideal patient-doctor relationships, patient-researcher relationships, maybe some points that anybody has pulled out of our session today. And if no one has questions, I have more questions for Ms. McDowell. So.
Thank you so much for that. There is one question. Would you suggest women of color participate in research and clinical trials to help improve representation both at the patient and physician level?
Yeah, I mean, I highly encourage clinical trial
Yes.
participation, just because, like I said, as we are developing drugs, we're developing drugs that don't work on certain populations because of the underrepresentation. Now, the healthcare system has some ills to correct before we can expect different communities to just jump on board with clinical trials. And so I think that it's imperative for researchers to have community partnerships in order to understand the needs of the community that they want to serve.
Right.
And so I would encourage patients to learn more about the clinical trial, ask to talk to, the people actually doing the research. Don't just sign up for it. That's not what I'm advocating for. Definitely, talk to them, make sure they understand your point of view, and then consider it. But yes, it is encouraged to consider it. I don't know, Ms. McDowell, if you have something to add to that.
I just want to say the timing is very important, because when you're going into treatment, it's hard enough that you're having to grapple with this, but you have to get your mind ready for it. And it's really mind over matter. And so I needed to calculate how long I had to endure this, and changing my target to push it further away was not ideal when I barely feel like I came out of where I just came from. By the time it was presented to me, I was done with chemo, heading into the surgery piece of it. But chemo was rough. I had all the side effects. I had all of the things that you don't want to have happen. We had to go back. Triage was like my second home. So timing is everything. If I would have known that that was the plan in my mind, I would have planned further through my treatment journey, and I would have been able to actually endure it because I had my mind set for it. So it's important.